motor disorders as well. And so they certainly have a role. And I think it's best to understand kind of how they serve this. When we think about them as anti-seizure medications, we think about sort of abnormal electrical activity in the brain. And electrical activity in the brain that can be disruptive can occur from a lot of different pathways. And so there are all these different channels of sort of either sort of neuro sort of modulating agents or sodium or calcium channels that kind of, if released, can sort of decrease sort of electrical flow. And so all of these medicines kind of share in some capacity either two sort of primary purposes. One, they block something to reduce electrical activity. So they're either decreasing sort of the excitatory potential of the brain, or they're increasing the inhibitory potential of the brain so that the seizure threshold is higher. And so when we think about sort of neurotransmitters, we have some neurotransmitters that are sort of excitatory, like glutamate, and I have some that are kind of inhibitory, like GABA. So these medicines are like big hammers in a lot of ways. They hit a lot of different receptors and sometimes a combination of different receptors to either increase that inhibition to decrease electrical activity or sort of decrease the excitability. And they do that in lots of different ways through lots of different patterns and are widely sort of different in their roles. One of the things that we see a lot in psychiatry that makes it really confusing is that every time a new anti-seizure drug comes out, someone says, oh, I wonder if that will help in psychiatry. And so what you sometimes see is a lot of newer psychiatric agents or newer anti-epileptic agents getting tried out for psychiatry reasons. And so the ones that are at the top of this page, and I'm going to talk about them a little bit more specifically, are ones that do have some evidence. Now, if we think about what inhibition or increase inhibition or decrease excitement, we can kind of think about what might that help with. So one thing that some of these anticonvulsants or AED medicines might help with in psychiatry is mania. Mania is kind of conceptualized a really excitatory state of the brain, kind of the brain on fire, things are kind of firing, out of control. So many of these agents can sort of suppress mania. Some of the agents also inhibit impulse control. So you may see sort of disorders of inhibition or of reactive behavior, sometimes being a target. And some of the medications that increase inhibition, like GABA, that's how benzodiazepines work, may actually decrease anxiety by helping the brain kind of return to a resting state. And so many of these agents will be kind of tried for impulse control, mania, mood disorders, or anxiety kind of states or withdrawal. And so many of them have that. The part that I want to highlight is that lots of times people try agents that don't really have a lot of evidence. And three of the most common ones that have come out lately that again are for seizures don't have as much evidence in truly treating psychiatric conditions. But when you're kind of messing with sort of the neurotransmitters in the brain, people can still report things. And so some people do report some symptomatic relief sometimes, like they feel calmer, or they might be less impulsive, or they may have still a response to medicines, but in terms of really truly treating a diagnostic psychiatric condition, we really don't have any evidence or failed evidence, especially for the three at the bottom. So oxcarbazepine or triliptylin, a lot of similarities to tegretol, but it didn't require lab work. And so people really had a lot of hope that triliptyl might help with some mood disorders and bipolar disorder, but it really didn't pan out that way in the adult studies. And there are virtually no studies of high quality in children. Keppra is also a very broad spectrum agent, and for many pediatric neurologists, Keppra has almost become one of the primary agents of choice for seizures, especially generalized tonic-clonic seizures in neurology. And again, it just has not had a lot of robust psychiatric outputs. In fact, Keppra has sort of the unfortunate effect of actually maybe having some negative behavioral and psychiatric outcomes. And so as it has become one of the preferred agents for seizures, we sometimes see that kids, when started on a new seizure medicine, may actually have psychiatric side effects from that medicine. And Keppra is well known to kind of worsen mood states and irritability and cause some behavior disruptions. And again, these are often in kids that just have seizures that sort of have mood symptoms that emerge after the start of the but it has not been shown to have much efficacy for true psychiatric illness. Zonegran is not used as much anymore. The zonisamide is still used for seizures, but over the last decade or so, people have tried to find more psychiatric purposes for it without much evidence. So those three at the bottom often, again, may cause psychiatric symptoms as a side effect, but have not really been found to be efficacious. So the ones at the top, the valproic acid, the lamotrigine, the Tegretol, the Topamax, the Neurontin, the Lyrica, those have been shown to have some clear targeted psychiatric benefits. So it was a little bit more. So with regards to pediatrics, explosive in nature, kind of when you talk about sort of like behavioral mapping for behaviors, you talk about sort of the antecedent, what's leading to the behavior, which is the aggression, and the consequence, what happens afterwards. So for kids that are kind of very explosive in their irritability, it's often clearly triggered. There's usually an inciting sort of event or misinterpretation, and they kind of go 0 to 60 thinking, and they often afterwards will report significant kind of remorse and neglect. Sometimes those kids will respond because that 0 to 60 sort of aggressive explosion is kind of like an adrenaline surge that kind of takes over with the behavior. And by, again, sort of suppressing some of these excitatory systems, that there has been some evidence that these medications can help for reactive aggression. That's different than kids that purposely choose to be aggressive. So if I give the example, if you have a kid that doesn't want to go to school, or they don't want to do something, they want you to call your parents, and they decide to punch someone so that then you have to call their parent and send them home. They planned that out. It was intentional. Medicine isn't going to help that kind of behavior. So that's sort of the difference between reactive and sort of like a pre-planned behavior, purposeful behavior. But Depakote or valproic acid does have some evidence in conduct disorder and aggression, and has been used in adults for especially rapid cycling bipolar disorder. It is a very good anti-manic agent. So it is very much, it definitely has some strong studies for aggression and mania. Lamictal, now I'll tell you a little bit about side effects later. Depakote has substantial side effect burden, especially in females, that we'll talk about, that does limit its use a little bit in this population. Lamotrigine or Lamictal is approved in adults for bipolar disorder with more prominent depressive features. So when we talk about bipolar disorder, we talk about thinking about their burden over the span of their illness, how many depressive episodes they have, how many manic episodes they've had, how many mixed episodes they've had where they've had both symptoms of depression and mania. And for a lot of people with bipolar disorder, the burden is not with mania. The burden is with recurrent or severe depression. And this is where lamotrigine has really been helpful as an anticonvulsant, because it can be very helpful for depressive symptoms, especially as part of bipolar severity. And in a lot of adults, it's actually used first line for bipolar depression. We do not have as much data in adolescent bipolar disorder regarding this use, but there is substantial case studies that do support its use, especially in teenagers for depression. The negative part of Lamictal is that it is not a good anti-manic agent. So if you have someone that's truly manic, lamotrigine is not going to be helpful. And when we talk about dosing with lamotrigine, it is so slow. It takes a good 2 to 3 months to get the dose up to a dose that's helpful, that there's a definite time lag that is required and consistency with taking it for it to work. But one of the reasons it's a popular agent is because it has substantially less side effects and no lab work related to it. So it's becoming more and more in use. Topiramate or Topamax is actually not FDA approved for adults or children with psychiatric illness, but it definitely has some utility in a lot of different areas. So Topamax, again, by virtue of blocking some of that excitatory events, has been helpful for some impulse control disorders. And they have used Topamax in things like alcohol use disorder and things like tics and some impulse control disorders like kleptomania to kind of reduce sort of that excitability. The other role that Topamax has sometimes played is in binge eating. They've used it to kind of, it actually suppresses appetite a little bit. And so there's been some evidence that it can help the sort of binge eating, which also has an impulse control component to it. So you see Topamax used for those kind of things. Several years ago, they tried to take advantage of Topamax's tendency to promote weight loss for that binge eating and tried to add it to medicines that increased weight, and it was really not successful for weight gain related to other medications, but was really only successful as a primary kind of eating disorder. And then the other two anticonvulsants that were on that list, gabapentin, which goes by Neurontin, or pregabalin, which is Lyrica. Again, don't have a ton of data in pediatrics, nor does it have an FDA indication, but these medicines are very highly GABAergic. So GABA is that primary inhibitory brain chemical. And so it's also what is increased in medications like benzodiazepines that help with anxiety. And so there are actually really robust data in Europe. And in Europe, they tend to use these medicines a lot more for anxiety disorders. There's very good adult evidence for the use of Lyrica and Neurontin for social anxiety. And this may have some benefit in pediatric patients, but there is much less evidence in pediatric patients for this use. Probably the most striking thing that has happened with Neurontin in the last couple of years is that it was categorized as a higher scheduled medication. I believe it's Schedule 3 right now. It had moved up the list because there was some potentiation that was happening with Neurontin and other substances of abuse that was contributing significantly to overdose risk. So if you think about GABA being inhibitory, you think about GABA sort of suppressing respiratory drive. People were kind of especially using Neurontin alongside opiates. That was contributing substantially to overdose risk and death. And so as part of a lot of the changes regarding sort of prescribing as a result of the opiate epidemic, this medicine was scheduled as a control. And so people are much less likely to use it nowadays than they were before, but it definitely still has some utility. By far and away in pediatrics, these medicines and the use of these medicines probably really exceeds their evidence base, but they do have a place, certainly, and sometimes it is a better choice for kids when you take it from all perspectives. The challenges with, again, most of the medicines that we're going to talk about today are the side effects. Weight gain is going to be a theme of most of the medicines I talk about today. And all of the anticonvulsant mood stabilizers do tend to cause weight gain. The exception, again, are Topamax and the lamotrigine, or the Lamictal, that really are found to be weight neutral, but almost all of them can increase weight, especially Depakote and Tegretol definitely have those as side effects. These medicines tend to have a bit of a burden of GI side effects. And one of the challenges with anticonvulsants are regarding females, of which most adolescents are females that are also childbearing age, that these medicines, because they hit so many neuronal systems, really have had very strong links to birth defects, especially neural cord defects. And Depakote is one of the worst offenders of that medicine, but Tegretol is as well. And the problem with those agents is they often cause the damage before people know they're pregnant. So you can see substantial impacts on the developing fetus's neuronal sort of network, even before, within 4 to 6 weeks before most people would know they were pregnant. So really, if you're going to use these medicines in female patients, they really need to be on comorbid birth control in some regards. Depakote or valproic acid also has substantial burdens in females, again, regarding polycystic ovarian syndrome. It can be quite problematic and certainly worsen this condition, and again, cause reproductive consequences. So although Depakote can be a very helpful agent for mania and for that explosive aggression, it really has so many limitations, especially in females, that I tend to kind of avoid it at most cost. All of these medicines, especially the psychiatric ones, Depakote, Tegretol, really do require pretty regular lab work monitoring. There can be substantial things that can happen. Depakote can cause abnormalities in the liver, as most of these can, because they're metabolized that way. There can be changes in the white counts and sort of immune functioning that can come, and you can get low platelets and easy bruising. Depakote has a warning for pancreatitis. There's a lot of monitoring that goes in with this. Of those on the list, valproic acid is really the only one that has like a therapeutic level. And you'll see people checking a valproic level. But the problem with levels with these medications is that the levels always refer to their seizure potential. We don't know very much about the level as it relates to psychiatric stability. It can be helpful if someone's stable to check their level and know what level they're at that's stable. But the levels have always been linked to seizure control and not so much psychiatric outcomes. So that makes it a little bit challenging. Many of these medicines, especially the topiramate, can have, because again, it's hitting all those different brain neuronal pathways, can cause a lot of memory problems and cognitive symptoms. We sort of jokingly refer to Topamax in child psychiatry as Dopamax. You get much above 50 to 100 milligrams, people really start having some clear cognitive issues in their ability to retain information. Lamotrigine or Lamictal, although probably the least burdensome with regards to side effects, does have a risk of Stevens-Johnson syndrome. It's very severe, it's very rare. Sometimes people report it's probably 1 in 10,000 in pediatrics, and probably closer to 1 in 1,000, 1 in 10,000 adults, maybe closer to 1 in 1,000 in kids. But the problem with lamotrigine is that risk of rash is significantly higher if you escalate the dose too fast. And so if you have to start at 25 milligrams for at least 2 weeks and can only really increase by 25 milligrams every few weeks, the target dose, especially for bipolar depression, is probably 150 to 200. That's going to take you many, probably a couple of months to get to the dose to go slow enough. But the problem is if people skip a dose, and teenagers in particular are inherently non-compliant, if they skip a dose, then they you have to start all over again, because it's really, if you increase the dose of lamotrigine too quickly, or they've been off of it and restarted, that's when the risk of the rash is most severe. Certainly in kids that do have comorbid seizure disorder, this is where sometimes I get a lot of questions and have a lot of communication with the pediatric neurologist, is sometimes when there's also a seizure disorder present, then it actually is helpful sometimes if they have two problems to pick a medicine that treats both. And so, for example, if you have a child with seizure disorders plus maybe significant aggression or significant like bipolar risk, maybe choosing Depakote is a better choice because it can treat both. And those are things that we often sort of work with. And then of course, these medicines have lots and lots of drug-drug interactions, affect the metabolism, and can affect the metabolism of other drugs. So you have to almost double and triple check those reactions. And as we already mentioned, the gabapentin has really kind of has developed abuse potential as well. Any questions about the anticonvulsants before we talk about lithium? And I can't see the chat, so if someone who can see the chat,
I'm watching it for you.
okay, would read them to me, I would appreciate it.
I'm trying to. Can you guys hear me?
Yeah.
Good. Okay.
So lithium, I'm giving its own sort of class to lithium because lithium is kind of a unique agent. Lithium is a salt. It gets mined out of the ground, and now we mine it for batteries and all kinds of things, which has actually, interestingly, really driven up the cost and accessibility of lithium in today's market. So this was a dirt cheap couple dollar a month medications, and as it became popular in batteries, it's become actually harder to find, and prices have really gone up. But lithium has probably been sort of linked to the savior of psychiatry in terms of being one of the earliest medications that truly was helpful. And so it is a control. You can't create lithium. It's its own element. So there really is probably a limited supply of lithium in some regards out there. But lithium is a very important medication that may have really significant benefit to a lot of different people. It's a medicine that also is hard to use, requires lots of monitoring, and if you reacted to the word lithium, then you already know that it's highly stigmatized and people have lots of feelings about that word. I don't think I have ever suggested lithium without getting a almost negative reaction to someone because it has been so I think misunderstood. But it really does have some significant benefits. So it is actually approved for bipolar depression, and is actually approved for bipolar depression in adolescents as well as adults. So this one really is truly on label. And the beautiful thing about lithium is, again, we talk about those phases of bipolar disorder. We have our depressed phase, our manic phase, our maintenance phase in the middle, and then the mixed episodes. Lithium is really something that covers all of those different phases of illness. And there also seems to be some clear genetic heritability in families, that if you're a lithium responder in your family, that you have a really good chance of being a lithium responder. And so when you have people that have had substantial sort of depressive irritabilities with both mania and significant depression, lithium might be a really good choice for those patients. Many of those agents only help depression or only help mania, but lithium can really be a single agent for many people that will cover both. The other thing that has really been helpful to realize is, although there's a lot to be said for treating underlying conditions and protecting against suicide, but lithium, as well as clozapine, which is an antipsychotic that we'll mention briefly, have really shown to be specifically helpful for protecting against suicide. And so when I have patients that have had multiple suicide attempts, either severe recurrent depression with suicide or considering for bipolar spectrum, lithium has been shown in its unique ways to have more benefits over recurring suicide attempts. And so it's probably important to remember that. Now that's balanced against the fact, as we talk about lithium side effects, that if you overdose on your lithium, you can die. But the reality is that it's such effective medicine for mood that it can really prevent those that have had their suicidal thoughts as part of depression can really be helpful. But lithium, and the reasons people's eyes go up when they get scared about lithium is it is really potentially, again, a complicated medicines, much like the antipsychotics I'm going to talk about next. This absolutely requires lab work. It's a salt, so it goes through your body just like salt does. It goes through the kidney. So anything that impacts your metabolism, your hydration status, your kidneys, can really affect the level of lithium in your system. So if you get really dehydrated, your lithium level can creep up, or if you overhydrate, your lithium level can go down. There's some adaptation to that over time, but it certainly is problematic. There is an abnormality called Epstein's anomaly, which is, I believe, effect on the sort of a atrial. It's a valvular defect that's very specific in the first trimester of pregnancy from lithium. So it definitely has some warnings in pregnancy, but actually the Epstein anomaly is actually probably one of the most rare side effects. And so compared to some of the other medications, sometimes lithium is a preferred agent later in pregnancy because it's maybe less significant than something like an anti-seizure medicine that probably has more risk, but the risk is there. This medicine can cause weight gain. It may not be as severe or significant as some of the antipsychotics, but it is a warning. This medicine can cause thyroid problems. It can worsen acne, psoriasis. It can have a lot of stomach effects. There are actually different ways that lithium comes to try to prevent the stomach upset, but people can get kind of nauseous or sick at their stomach from it. And as the dose kind of increases, some people can get a very fine sort of tremor that's really uncomfortable. And if you do take too much lithium, it can certainly be lethal or require dialysis to clear it, because it does have to go through your kidneys. So again, those are a lot of scary side effects for a lot of people, but it certainly has a place in folks with significant bipolar symptoms or depression with suicidality. Any questions about lithium? Okay. I'll also say that even in patients that don't have bipolar disorder, there has been actually some addition of lithium to antidepressants to sort of boost antidepressant effects. So the lithium add-on treatment has actually been helpful for just primary depression too.
Can I ask a quick question real fast? Yeah. With lithium, I had a client that was, when I was a child, it really didn't do much for the behaviors, but every time that I know you have to get tested to make sure the levels, but every time they would test him, his levels were really low. But the doctor was never really willing to go up, and then they ended up going to a totally different medication route altogether. But what is the significant, I know there's like a high rate of toxicity with this. Is it more so in adults or children, or is it something you always have to have while you're on lithium to get your blood checked? Or
yeah, so thank you for asking. I forgot to even mention that entirely. So lithium is actually one of those medicines that is very specific to the level. And when we talk about the levels in lithium, actually that's really linked to efficacy psychiatrically, which is different than the thing. So I'm just going to throw out some numbers there, but just to sort of put it in perspective, the level that you want to kind of achieve with lithium really depends on kind of where the stage of illness is. So there's actually there have even been studies in like stroke rehab of adding lithium to like stroke patients, because it's felt to be almost neuroprotective or increase neuronal growth. And so when they've talked about sort of neuroprotective effects of lithium, they're talking like microscopic doses. That'd be like a 0.1 or a 0.2 lithium level. But that type of level isn't particularly helpful for mood. And so if you're using lithium to kind of treat depression, primary depression, augmentation of SSRIs, you're targeting more of maybe a 4.5 to a 4.6 level. If you're using it to target severe mania, you're probably looking at a 0.8 to a 1.2 level. So if you're really using it truly for behaviors or impulsive aggression, and I should have added that lithium actually does have some data for like conduct disorder and severe impulsive aggression. If you're really using it for that, you'd really probably want to try to get up to those higher levels, 0.6, 0.8. And so if the child's level was always low, then they probably really didn't get an effective trial of lithium. And so you have to do a lot of education with lithium on the front end, because once you get to the level, you want to maintain it. And some of that maintenance of the level sort of depends on sort of regulating fluid intake and making sure people don't use ibuprofen, because ibuprofen will block some of the renal outflow and can increase the level. So we usually tell people on lithium not to take ibuprofen, to use Tylenol for pain instead. And so, but once you get a stable level, you don't have to keep repeating it. You actually can get a good lithium level, like per dose, you check it every 5 days. So when you get someone really stable and they're on the level that works, and you kind of educated them about what to monitor, you really probably can go to checking the level once every 6 months. But it's probably in getting it on that front end. So, and not everyone responds. So if I'm going to use it in a kid, or I'm thinking about like if I'm using it for behavior, I'm using it for mania, if I'm using it for depression, I'm going to be kind of aggressive at the beginning, checking the lab work to try to get to that level, because they probably will not get any efficacy until you get to the right level. So then it kind of goes back to what I've said before. If you don't use it to a level that can work, you're exposing them to all the side effects and none of the benefits. So if you're going to use it, you do want to try to get it to the level that works. And then if you get it to the level that it's supposed to be and you're still not seeing any benefit, then you can consider that a failed trial. But that really is an important thing to remember, is a little bit of lithium here, if you're not targeting the right level, probably isn't going to do a whole lot. So that's a really good point, Mariah. Thank you. Did that answer your question a little bit?
Yes, no, yes, yes. Thank you so much.
That was a great one. Any other questions about the lithium? Okay, so the atypical antipsychotics are a big deal. They sort of are big deal medicines in a lot of ways because they're really highly regulated, and they're highly regulated in children, especially in our state. But one of the things that led to this regulation is that lots of antipsychotics were getting prescribed for lots of different reasons. And at one point in time across the country, there was an average, I think, of 4.5 drugs for kids in foster care. And some of these drugs ended up being antipsychotics, and they had lots of side effects and lots of problems. And so there was a lot of lawsuits going on and federal regulations to try to limit inappropriate prescribing to kids. And antipsychotics really, which have always had very clear things to monitor and use, got very much sort of highlighted in that. So it is really hard actually to get a kid on an antipsychotic in the state of West Virginia and most places. But it probably is true to say that most of the efficacy we have for serious aggression, autism, severe behaviors, schizophrenia, bipolar disorder, much of the evidence is for these medicines. So you really do want to understand them. And these medicines do have clear FDA indications that really are important. Now, even if you have a clear FDA indicated diagnosis, it can still be a hurdle to get these medicines filled. And you probably have heard patients who go to the pharmacy and they can't get their prior auth to go through, because every time you change the dose, every time, then 6 times a year, you have to submit the lab work. They won't even fill it if the labs aren't there. It's a lot of regulation to get these medicines, but they really truly have some clear utility. And again, in pediatrics, they have clear FDA indications. So across the board, all these medications are truly antipsychotics, and they are all approved in adults for psychotic disorders. So psychotic disorders include schizophrenia, mood disorders with psychotic features, bipolar disorder. And antipsychotics, all antipsychotics are also anti-manic agents. So if you hear the term, you could be on an antipsychotic because you had auditory visual hallucinations or paranoia, but you could also be on an antipsychotic because you had true mania. And all of these medicines on this list, although antipsychotics, also are really good anti-manic agents. And so those terms often overlap in our utility of these medicines. So if you see a patient on a medicine like this, you might not know what it's for. It could truly be they have a psychotic disorder, or they could have bipolar disorder, or they could have had a manic episode, or they could have had autism. And one of the other sort of indications, and the way most of these work, this is really global because there are other ways these work, but the antipsychotic, some of the antipsychotic effects of these medicines have been linked to either a specific serotonin receptor, or most of the time a dopamine blockade. And dopamine blockade, if you think about dopamine as your sort of excitatory neurotransmitter, dopamine blockade not only treats psychosis and mania, the dopamine blockade causes some of the side effects we're going to talk about. The dopamine blockade also sort of blocks impulsive aggression. And so 2 of these medications, the risperidone and the aripiprazole, actually also have approval for aggression and severe irritability associated with autism disorders and developmental disorders like intellectual disabilities and some of the other sort of things. When you look at like just outright aggression, that reactive aggression, explosive behavior, that dopamine blockade seems to really play a role in severe explosive aggression. And so the indications for the ones in yellow are for all 3: pediatric bipolar disorders, schizophrenia, and autism disorders. The green ones have indications for bipolar disorder and schizophrenia. And all of these medicines, you have to kind of, as I said, they're all antipsychotics. Actually, some of the other antipsychotics other than risperidone and Abilify have shown some evidence in autism for aggression and irritability. But the other thing about these is that, again, some of them may have different degrees of ability to treat depressive symptoms or not. So they all are anti-manic agents when you're talking about bipolar disorder, but some of them have some antidepressant effects and some of them do not. Most of them do not. Only Seroquel and Latuda on this list have shown much benefit in depressed phase of mania. I'm sorry, depressed phase of bipolar disorder. While they all are anti-manic agents, those two have some benefit for bipolar depression, but the other ones really have very little benefit. So if you have a patient that has severe bipolar disorder and they're on one of these medicines other than Latuda or Seroquel, and you treat their mania, but they have a breakthrough depressive episode, you may have to add something that treats the depression or switch to a mood stabilizer antipsychotic that has more depressive effects, because apart from Seroquel and Latuda on this list, the other ones don't treat a lot of the depressive phases of the illness. And so these certainly get used. I mean, there are other things to kind of be aware of and some challenges that occur. I don't want to get on my soapbox about sort of the overlay of substance use and pediatrics, but one of the other things that we're seeing a lot of is the risk of psychosis coming from substance use. Specifically, marijuana has been a huge offender of this. And I have had kids with no prior psychiatric history showing up like acutely paranoid or hallucinating from probably triggered from their marijuana use or stimulant use or meth use. And sometimes they need an antipsychotic, even in the short term, to treat the severity of their symptoms. And so it's a very different indication than someone that needs a long-term maintenance medication. But they do have clear, and they also have shown some data regarding just straight up aggression. So there's several studies about pediatric aggression and kids that have had long-term aggression. And by aggression, I really mean specifically reactive, physical, explosive aggression. I'm not talking about oppositional kids. I'm not talking about kids that backtalk or verbally make threats. I'm talking about kids that violently assault other people or have severe tantrums that injure themselves or others. There's definitely some data that these medicines might get to that point. There are typical antipsychotics, so the atypicals are kind of older agents, are newer agents, and they tend to hit more receptors. These are old agents, typical antipsychotics. These medicines have a lot of that dopamine effect. And so I just wanted you to have the names. Interestingly, the other sort of disorder that antipsychotics help treat are tic disorders. So movement disorders, motor tics, verbal tics that are part of Tourette's disorder or tics actually are manifested by dopamine. And so medicines that can block dopamine blockade actually can. And actually, haloperidol and pemazide, Haldol and Orap, are actually the only two medicines that are FDA approved for tics. But as I'm going to tell you here in a minute, there's so many side effects and risks from these medicines that they actually aren't first line. So remember when I told you sometimes that FDA approval doesn't always mean that those are the best choices. This would be a good example of that. I don't know if anybody remembers from the past lectures, but we actually probably use things like the blood pressure medicines, those alpha-2 agonists, such as the guanfacine and clonidine, more preferentially first-line treatment for tics than we do antipsychotics. But all of the typical and typical antipsychotics that have some degree of dopamine blockade also have some evidence base for tics. And so kids that have really severe impairing tics that fail those alpha-2 agonist blood pressure medicines, you could consider this class of medicine for. Again, generally speaking, most of the time we don't treat tics. We just kind of watch and wait and do a lot of education that the tics will likely get better. But some kids have very complex tics and they end up hitting themselves or have severe pain, or they get really embarrassed by the tics that sometimes it's indicated to treat it. So again, we talked about those specific FDA sort of indications, but when we look at the evidence base, we definitely see some wider kind of use of these medicines, especially around that explosive dopaminergic blockade effect. So we certainly, the actual FDA indication for antipsychotics for autism says irritability, temper tantrums, and aggression, kind of in the context of autism, and Resperol and Abilify carry that approval. They are also used, as I said, all could be used as anti-manic agents and used for psychotic disorders such as schizophrenia. And then the more off-label uses are your severe impulsive aggression with significant physical violence, tics, impulse control disorders, psychotic symptoms for other reasons, such as we said, substance-induced psychosis. And then interestingly, in adults, they've actually shown, there's also Rexulti that's on the market as well. You've probably seen those ads if you've watched television. They're starting to use some of this low dose antipsychotics that have more of a dopamine modulator ability. So Abilify is one of those medicines that in some places activates dopamine and other places blocks it. And they're using that mechanism in low doses to actually treat depression because there's that modulation effect. And so Abilify, and I believe it's Rexulti, but I'm not remembering the brand name, but you'll see those ads because they're expensive and still being marketed by the drug companies, that they've shown some benefit for depression. The problem with these medicines is they require lots of monitoring, which is why they have all that paperwork. And so every 3 months and then every 6 months, I have to submit not only lab work, but vital signs and a movement scale to assess for side effects to get these approved in kids because they do have a lot of risks. So weight gain is by far the most profound issue with these medicines, and it's not mild. About 50 to 60% of kids will gain weight on these medicines, and that can be kind of really hard to treat. I don't have a slide on this, but people had tried the topiramate, the Topamax, to kind of block that weight gain, and that did not work. Diet, exercise, and actually the addition of metformin, which is a diabetes medicine, has shown some ability to maybe counteract weight gain, but weight gain is a significant problem with these medicines. And that weight gain can lead to all kinds of other risks with insulin abnormalities and lipids. So you can have kids' lipids go up, you can have new onset diabetes that can occur. So you have to monitor those things. And then you have movement issues. You have extrapyramidal symptoms. That's from that dopamine blockade. And that could be anything from tremors to restlessness. We call that akathisia, where you feel restless and you can't sit still. And sometimes that's hard to tell the difference from hyperactivity if you've seen it. Sometimes people get stiff or have something called dystonia where their muscles kind of tighten, or they can have almost like a Parkinsonian symptom with like a shuffling gait or a cogwheel rigidity that has to be checked. It's a very rare but neuroleptic malignant syndrome can occur. This is autonomic instability. This is really severe. This is a medical emergency. People that would develop fevers or stiffness or confusion or changes in their blood pressure and pulse really need admitted. This is incredibly rare, but I've seen it happen on a few occasions. Often these folks do not metabolize medications appropriately. They often have metabolic issues in their SIPs that might contribute, but that can certainly be a risk. And sometimes it's not the medicine that starts it, but another medicine gets added later on that can trigger it, so that has to be monitored. They can cause a lot of stomach upsets, dry mouth. They really can make people sleep and get sedated, so you have to monitor for that. And anything that blocks dopamine, especially on those typical antipsychotics, like the old school ones like Haldol and the Orap and then the Risperidol, can increase prolactin, which can cause gynecomastia and can cause milk development, have to be monitored. So those are big deal things, and certainly they can lead to lots of other complex medical issues. So that monitoring is really pretty intense. And so what you have to submit to get the medicine approved for most insurances, but to have good monitoring, is you have to do the lab work at baseline before you start. That includes fasting lipids and glucose. And I usually get like a comprehensive metabolic panel. So I just check kidneys and liver at the same time. You do it at baseline, you do it at 3 months, and you have to do it every 6 months. Once people have gotten stable and have been on that same dose and doing well, kind of had normal labs for 2 or 3 years at a time, you can usually go to yearly at that point, especially with the insurance if they have a diagnosis like autism, bipolar disorder, or schizophrenia, where there's clear need for them to maintain and be on that medicine long term. they will usually start doing yearly approvals. And most of the change that happens with the weight and the lab work often is early on. I haven't seen a lot of people develop it later. It usually happens if you change the medicine or the symptoms change, but most of that early effect can happen actually very quickly within the first few months. You have to do Ames testing or checking for akathisia, and there's a Barnes akathisia scale you have to fill out, or an Ames test where you actually have to watch and observe their face and their body for any abnormal movements as well, and you have to submit vital signs. Just a couple other brief medicines we didn't get to talk about in our last few minutes is some of the other medicines that are out there for anxiety disorders. I'm not going to spend a lot of time on this other than to tell you that we really do not use benzodiazepines in kids much. The impact of risk of addiction and withdrawal, and because actually benzodiazepines, by that same mechanism of blocking the GABA, can actually impact learning. And so kids that are on benzodiazepines don't learn and retain information as well. So while I've occasionally used it for acute panic attacks, really in kids tend to avoid scheduled dosing of benzodiazepines. The other one that gets used a lot is hydroxyzine or Vistril. It's essentially a fancy Benadryl. While that may be, again, a short-term medicine for panic or to help someone sleep, there has been some data in using antihistamines long-term that can also impact kind of cognition and increase the risk of dementia. And these medicines don't have long-term utility reported in anxiety, but we tend to use those mostly short-term. Buspar actually has some negative studies in adolescents for anxiety. It's approved for adults for generalized anxiety disorder. But I have used it successfully to help kids with anxiety. Sometimes it can be used to sort of augment serotonin and SSRIs. And one that also sometimes can be considered is propranolol. Now, propranolol is a beta blocker you have to be cautious with if someone has like an asthma or a lung problem. But that we talked about dopamine blockade, but propranolol kind of also has some evidence in kids with significant aggression, and because it blocks the heart rate, it can actually be a reasonable alternative for like anxiety. Because it can block kind of the physiological effects of a panic attack. And propranolol is actually, if you've heard about medicines that they give for stage fright, that this is actually the medicine they'll give performers sometimes to take before they go out on stage. It doesn't quite make them as sleepy as some of the benzodiazepines does, but tends to block that increase in heart rate and sweating response that comes. And often if that doesn't happen, people can kind of work through the more cognitive anxiety. So that's certainly one we can use. And I think it just reflects that here. And those again are some of the side effects. The other thing I would also just remind people of regarding the benzodiazepines is in elderly and in kids, so usually under 16, you can actually get the reverse reaction with benzodiazepines. And that can be really scary. People can get really agitated. And it can look really scary, kind of the opposite of what you intend. So if I've ever used a benzodiazepine, I always have someone kind of do a test dose first in good supervision just to make sure they don't have that reaction. And if someone has a history medically of having an adverse reaction to anesthesia or procedure, sometimes it was because they got the benzodiazepine. And at least once or twice a year, they may give a benzo like in surgery or in a procedure for kids. The kid will go wild and look wild. And sometimes it's this reaction. Again, rare, but important to know. All right. And so hopefully that gives you all a final wrap up of the year of our medications. Does anybody have any questions for me?
I hope you guys can hear me, but very good presentation. Thank you so much, Lauren. So informative, and just complexities of medicine is just amazing to me that you guys have to like know all this stuff and keep it in your little files of memory. Does anybody have any questions or comments about the presentation? All right, I'll just make that announcement then. I'll make sure to have her slides in the recap email. Our next session will be with Colleen Lillard, and she'll be discussing maintaining professionalism. That'll take place on June 16th. Again, I apologize for my technical difficulties. Wow, can't speak. And Lauren, you did a great job doing both. I really appreciate that. Thank you, everyone. I hope you have a wonderful rest of your day.